Hi, everyone. We're live. It's Michelle Jones on Cuppa with Michelle. And I will just wait for a few of you to start jumping in because we have an amazing topic today. For those of you that have been following me, I've had my journey with the frozen shoulder, and I've had the amazing opportunity of getting help from doctors, from naturopaths, from chiropractors, and physiotherapists. So that have actually helped me find the right journey or the right type of treatment for myself. As all of you know, being a naturopath, being a health coach, I try and opt for things that are a bit more natural. And we also do realize that with certain ailments, with certain problems, we can't quite go fully natural. And the frozen shoulder, I feel, is one of them. So we've gone through, going and taking anti-inflammatories as per my doctor's request, got off the anti-inflammatories after I had my liver problem that came about from those anti-inflammatories. And I've since then did a combination of physiotherapy and doing what we call a perineural injection treatment. So that's what we're going to be talking about today, specifically neural prolotherapy, an alternative for injury and pain management. So to help me with this topic, I have my amazing doctor, Dr. Stephan Praet. Dr. Praet is a Dutch sports and exercise physician who's practicing right now here in Canberra. He is actually registered both in the Netherlands and here in Australia. He is also an associate professor at the University of Canberra Research Institute for Sports and Exercise. He is a sports and exercise physician that possesses specialist expertise in general medicine, orthopedics, radiology, and rehabilitation, plus allied sports sciences, including nutrition. So we know that in any issue that we have with the body, we cannot treat just one component of it. I always say it's an array of things that we have to consider. And nutrition and the effects of medications on us is one really important thing. So I thought it's really important to introduce you to Dr. Praet and to introduce you to one of his interests, which is called neural prolotherapy through lift-off perineural injection treatment to treat chronic myofascial nerve pain, tendinopathies, and TMJ dysfunction. It's also a treatment that's being used for issues like back pain, knee pains, knee injuries. And I'll have Dr. Praet explain all that to you. But for those of you that are in Canberra, Dr. Praet practices at the Oker Medical Center at Bruce and Kingston. So let's welcome Dr. Praet. Hi, Dr. Praet. Thanks for joining me today.
Good afternoon, Michelle. Good afternoon, everyone who's listening and joining us for this session. Thank you. Yeah.
Dr. Praet, before I actually got to know about you, I was looking for practitioners that would give me an alternative to my frozen shoulder problem. So a lot of the people that are following us today have heard my journey and my Facebook Lives on the struggles I've had with my frozen shoulder. And it's amazing that here in Canberra, here in Australia, we don't really have a lot of options available. One of the biggest things that we find easily recommended or usually recommended very quickly is that of cortisone injections. And I was really, really excited when I found out from my physiotherapist that there was someone here in Canberra that actually did an alternative. And that alternative is what we're going to be talking about today. But before we go there, how long have you been in Canberra, doctor? And why Canberra? Why not the Netherlands?
Okay. Well, I've been in Canberra since 5.5 years, and the reason to come to Australia basically was to broaden the horizon, but also I got an opportunity to work at the Australian Institute of Sport, which sort of a once in a lifetime opportunity. But then after 2.5 years, I decided to move to a private practice and even broaden my horizon of how not just focusing on high performance athletes, but also basically on the general public and keeping people active or helping them bring them back to their sport they're passionate about, basically. So a lot of people think that sport and exercise is not only there for the high performance athletes, and that was obviously the reason why I came to Australia. But it's actually what we're doing is actually translating that knowledge for solutions for that also work for the general public. So yeah, and why not the Netherlands? I think I can't believe it today, but we got sick of the rainy weather in the Netherlands, so that's why I came to Australia.
Except for days like today and yesterday, where it just rains.
Yeah.
But Dr. Praet, I love what you've shared there, and I love how you've said you've taken it from the sports and the high how do you call them, the extreme athletes, high-performing athletes, to the general public, because pain and injury is something that we experience all the time. And what I also found really interesting is that with my own journey, where I've had the frozen shoulder, and prior to that, I had what they call the tennis elbow. These are terms for sports. And I'm no tennis player. I'm no, whatever, basketball player, what have you, that would suffer from a tennis elbow, or a rugby player. But the normal everyday person can suffer from all these as well. How many of the patients that you see right now, or that you've seen through your practice, what is the percentage of them being athletes, and what is the percentage of them being just, your everyday ordinary person?
I think about 10% are athletes, and the rest is basically the average. Patients, it ranges from kids from the age of 6-7 years old to my oldest patient, 96, basically. So, if you understand the general principle of medicine and tissue healing, etc., that works at any sort of performance level, or at any age, basically, because we're talking about general principles, and that's how I like to practice medicine too. That it's basically trying to find the overarching, try to understand the underlying problem, but also look at the bigger picture, basically. And rehabilitation medicine is part of sport and exercise medicine, obviously, but we like to keep people active, and that's basically what I'm passionate about. And it sort of resonates with what you try to do, as basically as a longevity expert, is keep people active as long as possible, because that maintains their independence, and that's reflected in the different age group that I'm treating in my practice. Basically, is the full range of people who are very inactive, people who are very hyperactive, or even overtraining and overloading themselves. But the principles are very, very similar. And that's I think good to know that people who don't like sports, but they like to walk, or they like to stay active, and they can still benefit from a visit with a sport and exercise physician, either my colleague or myself. So yeah.
That's right. That's so true. So guys, for all of you watching us, join us with your cup of coffee or cup of tea. Dr. Praet and I have our cups. Dr. Praet's got a special cup there. And for those of you that are online, remember, you can type up your questions on your phones, and we can see them on the comment sections here. If you're following me on my personal page on Facebook, we will be able to still ask your questions from there, but not show it here on our comment boxes, but that's okay. So we're going to be talking about different types of pain, back pain, shoulder pain, knee pains. I'd love for you guys who have been told that surgery was your only option, or that pain will always be a part of your whole treatment program, to actually come and ask your questions, because Dr. Praet might just have the answer. I know for me, that was definitely a game changer. It was definitely a blessing in disguise, finding out about Dr. Praet from my physiotherapist. So rather than just doing the usual question and answer, because our topic is very new, it's not something that you hear a lot about. So neural prolotherapy is very new in the industry, and very new in Canberra, very new in a lot of other places. I've invited Dr. Praet to just share a little bit of a presentation for us to further understand what this is about and who it can help. And after he puts his presentation forward, please ask your questions, write them down, and we'll get more clarity and find out if this is something for you or something that you can ask your doctor about. Doesn't matter if you're outside Australia, we have a list of practitioners that you can go to that offers the same kind of service. So just, you know, ask your questions, type up where you're from so that we know exactly how to help you. So Dr. Praet, please go ahead and get started with your presentation for us.
Yep, I'll share my screen and the presentation. So, okay.
I'm really excited about these things because I think education is crucial in anything, and understanding what's available out there gives people more options. So here is Dr. Praet's presentation.
You see my presentation, Michelle? Yeah.
Yes, it's good.
Okay, excellent. Okay. Yeah, so the topic is neural prolotherapy or perineural injection therapy. And I'm going to talk about this as an alternative for the management of injuries and pain. So if you're interested in my credentials, my background, you can visit my homepage, drstephanpraet.com.au. It gives you some background information and my experience as an athlete myself. I used to be a medal distance runner. Where I'm practicing in Canberra on which days of the week. So that's for the people who are in the area of Canberra. But yeah, so these are the three main issues, the main topics that I would like to talk about. Basically, the role of connective tissue and fascia in both acute and chronic musculoskeletal overuse injuries. The role of cutaneous nerve entrapment as a cause of chronic myofascial pain syndrome, and then perineural injection therapy or neural prolotherapy versus prolotherapy, PRP, or cortisone injections as an adjunct treatment. And I'm going to show you a little bit the contrast between those so you know what we're talking about. Now, first, the role of connective tissue and nerve entrapment in musculoskeletal overuse injuries. And actually, this is something that that I even overlooked when I went through my training as a human movement scientist and subsequently as my training at medical school. Because when you get trained as a doctor, you actually don't learn a lot about connective tissue and fascia, and it has to do with how anatomy training works. Basically, we are getting as medical students, getting a cadaver that has been conserved in formaldehyde for 9 months, and then you try to do dissection studies on those and study the different components of the anatomy. But the first layer you have to go through is actually the fascia, and it's because of the conservation process. The fascia is really thick and it's wide and thick, and you can't see any detail basically. So you basically, you cut through that first layer, and then suddenly you see the muscles and the joints, etc. And then it becomes really interesting. But everyone overlooks that first layer, and what was the use of it? And actually, by going to a fascia research conference in 2009, it was a real eye opener for me, because that's actually where I'll start learning about the role of fascia in living tissue. And one of the key persons in the field are the group from Antonio Stecco and Carla Stecco, brother and sister, who worked and were trained in Italy in the University of Padua. And their father was also an anatomy professor. And they actually start doing dissection studies on people who just passed away within like 24 hours. And actually we're looking at fascia that was not basically this wide, dense connective tissue, but actually looking at the detail of it. And you actually can appreciate here how, for instance, what the nerve structures run and how the different layers actually are connected with each other. So basically you're looking at a three-dimensional web. And a video that I really can recommend, it's a movie recorded by a French reconstructive hand surgeon, Dr. Jean-Claude Guimberteau. It's called Strolling Under the Skin, where he actually takes you on this journey by using video microscopy and looking underneath the skin during surgery. Because as a hand surgeon, he was very interested in what was causing adhesions when they were doing tendon transfers. And trying to improve his techniques, you actually start looking at what actually was happening underneath the skin. And this videos really give you a very clear picture of what fascia is all about. And then actually you can even appreciate if you look at this picture, that this is very glistering. It's a fluid-filled structure, very detailed, that actually allows gliding from the skin and with respect to the tendons, the ligaments, and the muscles. So basically gliding tissue. And that tissue is actually really important if you want to understand myofascial pain, which is actually caused by the entrapment of nerves that actually run from the deeper part of the body and the limbs towards the surface, towards the skin. So, and this is like a diagram or a schematic drawing of the muscle here, a tissue, with the septa, which is basically the divisions between of connective tissue between the muscles, but also between the subcutaneous tissue, the fat tissue, and then the skin in blue. And the nerve basically comes from here and runs and kind of gets entrapped at different points where it actually or penetrates the different fascial or septal layers. And when nerves get entrapped, they can actually start causing pain. So at any of these levels, you can actually develop this fascial nerve entrapment, and you can see abnormalities in the nerve tissue, explaining some of the pain. So this is an experimental model of what happens when you actually put a tight band around the sciatic nerve in a rat. And actually you can see here is actually increased swelling proximal to the to where the compression is applied to the nerve. And basically we all know this, right? So if we would take our wrist and we actually flex our hand like this and hold it like this position, you put a lot of pressure on your wrist, and that's actually pressure will restrict the blood flow to the nerve. And actually, if you look at this detailed picture, you can actually see there are little blood vessels that actually go and supply the nerve tissue itself from blood, oxygen, and also glucose. And the glucose is really something important to remember. So this basically what I found, that if you constrict the blood flow to the nerve, you can develop swelling, inflammation, and pain. And this has already been known for quite some time, as you can see from these references from the 80s and the 90s. Now, our body, our skin and our joints are innervated by different peripheral nerves. And this is actually a schematic drawing of different what we call anatomical fields that are innervated by the different nerves, both on the front and at the back side of our bodies. So there are quite a number of nerves that can actually get entrapped. I have an example here of a clinical case that I saw actually when I was still working in the Netherlands. That came to see me. It was a young female football player, and she was actually had sprained her ankle. And when I saw her, that happened more than 10 weeks before she came to see me. And she was still suffering from this chronic pain in her ankle and her lower leg that no one actually understood. And when I examined her, basically, so basically had a normal sprain, right? An inversion injury, sprain of the ankle joint. What happened is actually she probably during that inversion injury, she sprained the fascia and actually developed these entrapment points, nerve entrapment points right over here and over there. And her ankle was really inflexible and had limited joint mobility. So I recognized that actually this was actually potential fascial nerve entrapment. So I actually injected this with glucose, and within basically 10 minutes, her pain level settled. And interestingly, her mobility immediately improved in the ankle because the fascia, that sleeve that runs from the foot all the way towards the knee, that actually suddenly relaxed and actually allowed the ankle to move more freely. And 2 weeks later, basically sent her to the physio for further rehab. And 2 weeks later, she was actually running again, and within a month was back to her original sport. Now, understanding the role of nerves, cutaneous nerves, in this sort of chronic post-traumatic ankle pain is an important one. Now, and there are different nerves that actually can get entrapped. And this is basically a drawing on the skin where these nerves typically get entrapped, and what subsequently can actually cause nerve swelling along the trajectory where the nerve innervates the skin. And This is, for instance, something that we often see as sport and exercise people with medial tibial stress syndrome or shin splints. Typically happens in adolescents who suddenly go through a growth spurt. The bones, the growth plates of the bone will grow very rapidly, more rapidly than the fascia, the sleeve, can actually grow with it, and you actually get fascial tightness. And because the fascia becomes tight, it actually restricts the blood flow to the nerves that penetrate the fascia that go toward the skin. And these people actually develop this chronic exertional lower leg pain. And I think the majority of my patients that I've seen with this, basically, they respond extremely well to neural prolotherapy using dextrose injections, which is safe. And it's sometimes even a diagnostic tool that helps you to differentiate between, for instance, chronic exertional leg pain from fascial nerve entrapment or a compartment syndrome, deep compartment syndrome. But appreciate there are different nerves that actually innervate these different parts of the lower leg and can get entrapped at different sites. And this has actually already been described by Netter, which is basically the most the most detailed anatomical atlas for the medical professionals use that actually describe detailed anatomical structures of these nerves. So although we didn't pay attention to it when I did my dissection studies, these structures are well described in the anatomy books, for instance, by Dr. Netter. But this is a bit older textbook that actually describes the anatomical variation between individuals and how these nerves actually innervate. So you can actually see that there is some anatomical variation where exactly these nerves can get entrapped, and so you have to also keep that in the back of your mind, that it's not a standard picture, but there are some variation between people. Now, another interesting case study that I saw actually when I was working in Dubai, when I was doing working as a visiting sport and exercise physician in 2018 and 2019, is that was this 61-year-old male runner, triathlete. People in Dubai like to be very active, and you wouldn't believe it because it can get really hot in the summer. But there's a big, I think more than 5,000 triathletes in Dubai that participate in these big events. But this 61-year-old male, he basically was a healthy person, but developed Guillain-Barré syndrome, basically paralysis, probably related to some viral infection in 2012, and had been hospitalized for 2 weeks. And when he actually recovered from the Guillain-Barré syndrome, he went back to his normal training, and he subsequently actually started developing chronic pain and tightness of his left calf, which started during a duathlon race. He had extensive physiotherapy, and he only had noticed some temporary relief from dry needling and foam rolling. And when he was running, actually, pain got so bad, up to 7 to 8 out of 10, that he had to stop running and rest, basically, and he couldn't actually continue his running. So obviously, this was going on for more than 5 years, and no one actually had found a solution. So when I examined him, I discovered there were multiple myofascial trigger points in the midline of the soleus muscle and the lateral aspect of his lateral gastrocnemius muscle. So I was still a bit confused because, like, what could drive this pain? So actually, I decided to do an ultrasound, and I compared the left side, the symptomatic side, with the right side. And what I want to show you here is actually it's basically a longitudinal ultrasound image of the calf muscle, and you actually can see here is the aponeurosis of the myotendinous junction, and underneath you actually can see here is some irregularity of the fibrillar pattern. So compared to the healthy side, the right side, where he was asymptomatic, and I interpreted that actually looks like he had some old muscle tear with some fibrotic tissue and increased blood flow if you do power Doppler ultrasound on that. And this corresponds exactly where he had most of his pain. I went a bit further and examined his leg a bit further to look at the areas where he was most painful. And what I actually discovered is that when you're looking at when you ask them to actually to plantar flex and dorsiflex his ankle, so basically move his foot, whilst he was on lying prone at the table, that actually there was a distorted gliding pattern between the fascia, which is that denser gray tissue, and the muscle. So if you compare to this side, you actually may appreciate that, first of all, this layer looks denser, compared to that, it's more like different smaller layers, which indicate there is actually fluid in between those layers. And so it looks like there's less myofascial gliding taking place, which could be an indirect indicator that there could be a nerve entrapment as well of the nerves that actually runs from here, and the different nerves that actually go to the skin. Okay. So my working diagnosis is that this actually has calf pain, could actually caused by entrapment of the medial cutaneous serial nerve due to a thickened fascia and sort of scar tissue of the aponeurosis of the soleus and the gastrocnemius lateralis muscle. But how do you find out whether it's actually the case? Because there's no other medical imaging technique to actually visualize those nerves, because the nerves are actually too tiny to measure and to actually visualize them. Even with the best MRI equipment, it's possible to pick up to see where the nerves are, and if you would be able to see something, you can't tell whether it's abnormal or not. So I obviously thought, like, well, what's the solution here? And obviously, you know, you're looking at different types of injection therapy that you could consider for this sort of muscle injuries. So basically, I want to explain a little bit about the different sort of injection therapies that are being used by sport and exercise physicians. And the first one that's been very popular in the United States is called prolotherapy. That name derives from proliferation therapy. And it's actually developed by and discovered by a surgeon. His name was George Hackett, who did actually quite some research in the 60s and the 70s on this. And basically, he was looking at how you can actually strengthen ligaments. And he was using, at the time, dextrose for this, basically a glucose solution in a hypertonic concentration. And that's basically sort of a way to, well, the idea is that the hypertonic solution causes a rupture of cell membranes, and that actually causes an indirect release of growth factors, which stimulates the production of new collagen. And they use that in the 60s and the 70s to strengthen, for instance, the ligaments of the sacroiliac joint in people with sacroiliac joint hypermobility. Now, a more sort of modern version of that is called the PRP, or the platelet-rich plasma injection. It's basically drawing blood from the individual that you're going to inject. You spin the blood, you actually draw up the autologous platelets with or without the leukocytes, and that actually contains a little bit of dextrose because of the solvent that is being used to as an anticoagulant for the blood. So when you spin that blood, you don't want it to coagulate. You basically use an anticoagulant that contains some dextrose. And you have to use a larger bore needles for this, because it's more viscous type of injection. The idea is basically very similar. You try to basically induce a new healing response by injecting extra growth factors that are stored in the platelets around the injury. And another sort of alternative to this is basically, it's called Neural Prolotherapy, which is actually using buffered 5% isotonic dextrose. So rather than using a hypertonic solution, you're using an isotonic solution. And the goal of that is actually to settle nerve pain and inflammation. And I'll tell you a bit more about how that could work and how we think it works. This is often combined with using fascial manipulation, because once you use the dextrose, the fascia relaxes, and that actually creates a window of opportunity for the fascia to start gliding and actually benefit from soft tissue therapy, for instance, or massage therapy. And that's something you can do every 1 to 3 weeks. While if you look at the classical prolotherapy using George Hackett's methods, it's something you use every 6 to 12 weeks, because you want to wait for the new injection take place before you actually have reached your plateau phase. So it's a bit similar to the PRP injections. And then often the most common injection therapy by orthopedic doctors or sport medicine physicians are the corticosteroids. Canacort is one example of that. And that's basically aimed at reducing inflammation. It's often not used in combination with physiotherapy. You have to use larger bore needles, use an anesthetic because it can be painful. And you do this every 12 to 24 weeks. The problem is that the corticosteroids actually is a catabolic drug, which actually stop the production of collagen. While all these prolotherapy and PRP injections try to stimulate the production of collagen. And if you do repetitive corticosteroid injections, you can actually weaken the tissue, and that can actually lead to tendon ruptures, for instance, in the Achilles tendon or in the shoulder. And I've seen several patients in my practice who had multiple corticosteroid injections for a frozen shoulder, impingement syndrome, etc., bursitis, who actually ended up tearing their tendons in their shoulder, which is can be quite painful, but also devastating from a functional perspective. And so, big difference between corticosteroids. It's very great to settle inflammation, but the price you pay is that you stop the production of healthy collagen. And while these more prolotherapy and PRP are actually aimed at stimulating formation of new collagen. Okay. So go to my next slide. So I decided in this patient that I saw, the 61-year-old triathlete, to using peritoneal injection therapy, because it's if you're injecting hypertonic glucose into a muscle, you can actually induce a new healing response. But on the other hand, it can also create more scar tissue, which is something you don't have when you're using 5% isotonic dextrose solution. So you actually can see my needle gear going in, and I was targeting the area that he had pain. And I did the same for the more superficial fascial layers. You can see that over here. So what you can actually see is the moment when I'm injecting the tissue. And interestingly, the moment my needle touches the fascia, he said, yeah, that's exactly the pain that I'm feeling when I'm running. So that helps you to differentiate, it's almost like diagnostic injection, where does the pain come from? So there was some scar tissue, but there was also some fascial involvement as well in this patient. I injected 8 times 2 milliliters of 5% dextrose. And 2 days after the injection, he basically was pain-free. Well, I saw him after 2 days, and we decided to actually start doing some gentle running exercises and calf strengthening exercises. And within 3 weeks, he was back to full training and running and had absolutely no pain whatsoever. Yeah. So obviously, this is a success story that I'd like to share with you, but I've seen many, many patients with this sort of issues that have a very quick response to peritoneal injection therapy when you're actually dealing with this type of fascial nerve entrapment. Right. So what is the evidence at the moment for peritoneal injection therapy or neural prolotherapy? So what do we know from a clinical science perspective? Well, basically at the moment, we have 3 peer-reviewed randomized clinical trials that actually looked at the effect of using 5% dextrose for people with chronic lower back pain and also people with carpal tunnel syndrome. And carpal tunnel syndrome is a very interesting model because that's a thick nerve you can measure. It gets entrapped in the carpal tunnel. So basically, there's pressure, constant repetitive pressure on the median nerve that causes nerve swelling and causes pain and paresthesia, so a lot of sensation in the hand. It's a very common problem. And these 2 studies that have been published in 2017 and 2018 actually show that that can help in resolving the problem for carpal tunnel syndrome. And I'll go into detail in my next slide. I will go into detail about these the background of and the results of this study. Now, so how can dextrose actually work? Why does it have an analgesic effect? And there are a couple of explanations for this, but basically we think that it actually works on the nociceptor, the pain receptors, or the TRPV1 receptor, or it's also called the capsaicin receptor. That actually plays a role in pain transmission in peptidergic C fibers. And this actually research that shows that the C fibers, when you expose them to glucose, their firing frequency drops. It also been shown that it potentially reduces the inflammation around the nerve tissue. And there are some ideas that when you're looking at this subcutaneous web, that when you're injecting a glucose solution around this web, that actually can have a potential to improve the gliding of the different tiny fibers there that you need for gliding. So by creating fluid in that tissue, you can expand the tissue and you allow for more gliding. So that actually can help in reducing adhesions and also help in taking the pressure off those nerves that went through there. So obviously, the big question is like, why do nerves become swollen when we apply pressure to them? And this goes back actually to studies published in the 1980s, where they looked at the effect of greater compression on the blood flow to the nerve. So remember that every nerve along its trajectory has little capillaries that supply the nerve from blood, oxygen, and glucose. And this is like fundamental research in animals. And what they found is that actually the acute compression on a nerve may cause persistent impairment of the intraneural microcirculation due to mechanical injury to blood vessels, causing a metabolic block, which is sort of a miniature compartment syndrome causing swelling of the nerves. And this is actually one of the pictures that they were actually showing in this in a paper in 1983, where you can see this is a normal cross-sectional microscopic view of a nerve, where you can actually see all the nerves are like tightly packed together. But after putting pressure on the nerve for 4 hours, you actually can see there's immediately swelling between the nerves. So probably caused by degradation of collagen, that actually reduces the water binding capacity within the nerve, within that tissue, and causes nerve swelling. And we know that swollen nerves, they don't conduct signals very well, but that's something we see in carpal tunnel syndrome, where there's obvious swelling of the nerve, which results in reduced conduction velocities along the nerve. So basically, if the nerve is swollen, you get involvement of this TRPV1, the capsaicin receptor, and that causes the release of calcitonin gene-related peptide and substance P, which causes this neurogenic inflammation. And that actually becomes sort of a process that works, because when there's more release of these growth factors, you get even more edema and swelling in the tissue. So the question is still like, what causes the nerve pain? Why this is painful? And so if we put our hand like this in a maximum flex position, why after 10 minutes everyone starts complaining about wrist pain? And basically that's because that pressure on the nerve causes ischemia of the C fibers. And those are actually pain receptors that actually transmit pain signals to your brain. But it also, the ischemia results in hypoglycemia, so basically a low supply of glucose, a low supply of oxygen, and acidosis, basically a drop of the pH. And what this group actually found, and this published in 1992, that the C fiber nociceptors, they extremely respond to hypoglycemia, so basically a lack of supply of glucose. And that's actually been very well and very elegantly shown in in this experiment, where they used basically the cornea of the outer layer of the eye of a rat, which is exclusively innervated by A delta and C fibers. And this has been a very well studied model to study the effect of pain. And so what they were able to do is they were able to measure the firing frequency of those C and A delta fibers, and they were able to manipulate the supply of glucose. So what they actually did was a very interesting experiment where they mimicked the effect of supply of glucose by actually infusing not D-glucose or dextrose, but actually L-glucose, which is basically the stereoisomer of glucose, which is metabolically inactive. So in other words, our cells are not able to metabolize L-glucose, but they are able to metabolize D-glucose, dextrose, because that's a natural form of glucose. This is something you can only make synthetically, it doesn't exist in nature. So what I actually showed here is that this is the baseline firing frequency, and then they switch from dextrose to L-glucose, and you can immediately see that that firing frequency goes up by about 650%. So these C fibers, they start firing like crazy, basically. And then they switch, after about half an hour, they switch back from L-glucose to D-glucose, and you see within an hour, these C fibers, they are back to baseline, so they start firing in a normal way again. Now, they also looked at the effect of hypoxia, and they found that also hypoxia, so reduced oxygen tension to the tissue, causes an increase in firing frequency of the C fiber, and that's exactly what happens, for instance, when you start pressing on a nerve and you basically reduce the supply of oxygen. But at the same time, basically, you also start interfering with the supply of glucose. And when you actually combine both lack of hypoxia and lack of glucose, so the L-glucose experiment, you actually see that the C fibers are more responsive to lack of glucose and lack of oxygen, because if you combine it, they still fire at the maximum rate. Okay. So while hypoxia only caused an increase of 200% in firing frequency. But this is a very fundamental study, an animal study, that actually shows how dependent those C fibers are depending on supply of dextrose. And interestingly, when they did the same experiment and measured the A delta fibers, there was actually no effect of hypoxia or hypoglycemia on these fibers. So it's exclusively the case for those C fibers. Now, these C fibers actually what we call so-called peptidergic fibers, nerve fibers, that can get up to 1 meter long. In other words, they basically run from your lower spine or your lower spinal cord all the way to your feet. And there are about 2 million C fibers in our skin with an estimated length of about 65 kilometers. And these C fibers are also called neuroendocrine cells because they actually release those certain substances like calcitonin, gene-related peptide, and the SP, which basically the substance P. So the C fibers in a normal, healthy environment, they maintain your homeostasis in the interstitial space, the space between the skin and the muscle and the fascia. And they're silent; they don't fire, they don't cause pain. But when you expose the C fibers to harm, and usually that's glycopenia, so low supply of glucose, that actually starts causing pain. And so that's a more mechanistic explanation for what happens when you start applying, when fascia, when nerves get entrapped in the fascia and start interfering with the actual supply of nutrients to those C fibers. All right. So what if you're looking at more sort of a whole body level? What happens when you're actually injecting 5% dextrose around the spinal cord? And this was actually studied by a group from led by David Rabago, who's a associate professor at the University of Wisconsin in the US, together with a group of people who also like Kenneth Dean Reeves and John Lifton, who have been one of the pioneers of using injection therapy using 5% dextrose. So this is a pretty interesting model because they looked at this in chronic low back pain patients. And it is a double-blind randomized controlled clinical trial. So what they actually did is they used a specific technique where they injected dextrose in the epidural space and from caudal epidural injection technique. And then what they found is that actually compared to saline, basically the placebo injections, they found that already after 15 minutes, you see a significant reduction in the pain scores that lasts up to about 48 hours, so 2 days. And then that effect is sort of worn off after 2 weeks. So that's which didn't happen basically in that group where they injected saline around the spinal cord. And obviously, it raises also other questions like, well, how does this work? But basically, one of the hypotheses that actually this dextrose may have an effect on those on the supply of dextrose to the C fibers that basically innervate the lower back. Another model for that I just mentioned before is basically the carpal tunnel syndrome, where basically due to overuse of the forearm flexors, that you develop swelling of the flexor tendons in the wrist. And because they are actually encapsulated by strong ligaments and the bone, basically the radial bone of the forearm, basically the swelling of the tendons causes compression onto the median nerve, restricted blood flow, and subsequently pain and paresthesia, etc. So what this group from Taiwan actually did was they injected a single dose of 5 milliliters of 5% dextrose into the carpal tunnel, and in a randomized double-blinded fashion. So people, neither the doctors nor the patients who were participating knew what was being injected, and they actually measured several aspects of the basically the functional outcome, as well as nerve conduction velocity and nerve swelling, as measured by using ultrasound. And what they actually showed is that the control group, there was hardly any change, whether you looked at pain scores, whether you looked at nerve conduction velocity, or whether you looked at swelling in that blue line, basically. But actually, the group that were injected D5W, stands for 5% dextrose in water. Basically, they saw already after 1 month a significant improvement in pain that actually lasted up to 6 months. Same in the nerve conduction velocity improvement, and same in the functional outcome and in the swelling of the nerve. So the conclusion of that study that has been published in Mayo Clinical Proceedings, which is an important medical journal, is that compared with the control group at all post-injection time points, the D5W group had a significant reduction in pain and disability, improvement in electrophysiological response measures, and decreased cross-sectional area of the median nerve. In other words, the swelling of the nerve improved. And that's actually why the symptoms of these patients settled. Now, that's a pretty good study, but obviously people say, well, I don't believe it. So they actually repeated the study and compare it to the standard treatment, which is the use of triamcinolone, which is basically corticosteroids, which is aimed at reducing the swelling of the tendons and indirectly improving, reducing the negative effects on the nerve. And basically, they found a very similar pattern, but it's during the first 3 months. So the corticosteroids that do work. However, the effect is only, as you can see in this dotted line, only doesn't last more than about 3-4 months, because then the effect wears off. It's completely worn off after 6 months, basically. And that's exactly what I see in clinical practice, that people getting this corticosteroid injection, they get better, a bit better, but then after 6 months, the effect has worn off, and then they end up getting surgery where they actually cut through the ligaments in order to take the pressure off the nerve. The problem with that is that it also changes the mechanics of the wrist and can actually speed up osteoarthritis in the wrist bones. So what they found in the dextrose group was basically exactly the same as in the other study, that they found an improvement in pain score, improvement in the function, and improvement in the nerve conduction velocity and the swelling of the nerve that lasted up to 6 months. Now, and so the conclusion of that study, published in Annals of Neurology, which is a high-impact medical journal, that compared with the steroid group, the dextrose group exhibited a significant reduction in pain and disability for the 4th to the 6th month. And D5W is more beneficial than that of corticosteroids in patients with mild to moderate carpal tunnel syndrome at the 4 to 6 month post-injection interval. And well, I think I really highlight this study, these two studies, because basically median nerve is a thick nerve that you can measure relatively easily. It's very, you have good reference values for it. But basically the nerve doesn't know whether it runs in the carpal tunnel, or whether it runs in the shoulder, or whether it runs in the leg, right? So this is the effect they see from dextrose on nerve recovery is basically universal. And that's actually how I've been using perineural injection therapy or neural prolotherapy in my practice, that when there's suspicion of a nerve entrapment or fascial nerve entrapment, they basically use the knowledge from these clinical trials and our understanding from animal studies in trying to actually restore nerve function, which creates a window of opportunity, well, to settle the pain and let people actually go through a rehabilitation program, and actually restore their normal joint function, their normal limb function, and basically allows them to regain their muscle strength, because in the end that's going to protect them from re-injuring and re-injuring their nerves by repetitive strain on the fascia and on the nerve. Okay. All right. So when I was working in Dubai, we had a 37 cases that actually we were able to follow over a period of 3 months. And in Dubai, it's mandatory that any patient that receives an injection therapy, they have to be called after 2 days, 10 days, and 6 weeks to ask for how is your pain, and that's something that's done by the nurses that they will work together with. So this was in a sport medicine practice in Dubai, up and running, where I worked for 1.5 years. And basically, these are the areas that we treated. So I sort of subdivided in different regions: on the head, neck and shoulder, elbow, forearm, lower back and coccyx, the buttock and the groin, the hip, thigh and hamstrings, the knee and the lower leg, ankle and foot. And this is actually the number of positive responses in percentage that actually benefited from this. So basically, at baseline, the pain score was 7.2 on average. And after 2 days, when they were called by the nurse, the pain level had dropped from 7.2 to 3.6. And there's a little variation, as you can see, shown by the standard deviation. After 10 days, the pain score was 2 or 2.1. So basically, it dropped about 5 points from baseline to after 10 days. And after 6 weeks, the effect was still there, as you can see. All right. Now, this is the total group, and this is actually the people who responded. So you actually see a more stronger effect in the people who do seem to respond, because the subgroup, 20%, doesn't seem to have a durable effect. And that's an interesting group, obviously, because there could be several reasons why they don't respond or why they don't have a durable response. Because most of my patients that I injected, they had immediate pain-reducing effect, but it didn't last, and there could be several reasons for that. And happy to discuss those in the question and answers session. But basically, what it shows that you get about 80% success rate if you look up to 6 weeks. And that actually is sufficient to create a window of opportunity for these people to actually do a proper rehabilitation program, because that pain level of 2 allows them to actually start exercising more, start regaining their muscle strength, etc., etc. Right. So if we summarize neural prolotherapy from a clinical perspective, well, remember that prolotherapy and neural prolotherapy are different things. So you have to differentiate whether you're using high or low dose concentration dextrose. It's a very safe, low invasive treatment for chronic myofascial pain, in my experience. There is actually level 1 and level 2 scientific evidence for clinical evidence for the effect of this treatment. So I think if you think a bit more holistic, then any nerve that has entrapped or has been overstretched and has been swollen should basically respond to the injection therapy. So sometimes I use it as a diagnostic tool to actually differentiate whether the pain is actually that patients report is actually coming from the area where I suspect there is a nerve entrapment. And obviously, you have to inform your patient or your athlete that there is a what you're trying to do here. But it actually, I have never had anyone who refused to treat, because the technique I'm using is is minimally invasive and very safe to do if you know where you inject the solution. I think it may reduce pain and sensitization and speed up rehabilitation. That's at least my experience now, based on more than 10 years of practicing this. And I think it's definitely safe, and I even think it's a more effective alternative for corticosteroid injection, especially in carpal tunnel syndrome. And that's basically backed up now by a very high quality study. Now, some practical recommendations. So if you get injection therapy with dextrose, then it's important to immediately use that window opportunity to actually stretch the fascia and actually create restore the gliding directly when the pain has settled. and when the fascia is more relaxed. It's part of a comprehensive treatment and rehab plan. Just doing injection and not doing the rehab afterwards is probably not going to be very durable. So that's really important to emphasize. And I think there are a few patients who sometimes have an initial pain-reducing effect, and then subsequently get this flare-up. And I have seen this most often in people with hypermobility syndrome who will easily overstretch their nerves, or their fascia and their nerves. And also people with so-called mast cell activation syndrome. And that often goes together. So people with hypermobility syndrome, they overstretch the fascia, which recruits the mast cells that subsequently, after 4 to 12 hours, causes a release of histamine, which actually flares up their symptoms. And that's something we actually, when I suspect that people have this, I give them a drug to actually, 2 drugs to actually stabilize their mast cell, which is basically montelukast, and an antihistamine to prevent that histamine release. And then they don't have that secondary flare-up after the injection. And that's an important thing to remember because there are some patients, a small subgroup, that actually can get some side effect from these injections. Not a dramatic one, but it's actually something to think about. If you want to read more about neural prolotherapy on my webpage, I have some background information in it with some of the references that I think are important. I'm happy to answer any questions that I have raised with my presentation, and I'm happy to answer those in the next sort of 20-25 minutes. So Michelle, I give the floor to yours again.
Dr. Praet, that was really amazing. I actually loved your presentation because you've compared all the different modalities. And as we always say to our clients here and the people that are following us, you really need to know what your options are. It's not enough to just agree all the time with your practitioner, with your doctor. You need to know what else is out there. And you just showed us all the really interesting ways of actually getting rid of pain and injury. The thing that I loved is I was actually looking at plasma injections previously, and I'm glad I didn't opt for that. Looking at the type of needle that was going to be used, I don't think I would have been okay with it. So knowing that we actually use really thin needles when we do the perineural injection, I think is a really big game changer for me. And for a lot of others.
Throughout the years, I really refined my technique by actually finding the most ideal needle, and I can show you it's a Japanese laser cut needle, and that's important to ask for if you ever get these injections, that the doctors who do it actually use the right equipment. I'm sure basically it's a 30 gauge needle, really tiny. I'm sure you can see it over here. You can hardly see the needle. But the important thing is not just the size; it's laser cut, which means that the tip of the needle is extremely smooth. So if you bring it if you stick through the skin, there is hardly any resistance from it, basically, compared to a mechanically cut needle. And these are 6 more expensive needles, but if you do multiple injections like I do, it's really around the nerves. You want to treat the whole nerve, basically. It's important that you use a minimally invasive technique and the right equipment and the right needles. And the only problem is when you...
Dr. Praet, could you just show that again? I've just put you on a solo layout so they can see it clear.
So basically, but what's the reason why doctors don't like to use a small needle is because it's difficult to inject through a tiny needle like that. You have to really use a lot of pressure, and it can actually damage your own fingers. So what I actually use is called a gadget. Stands for grip enhancing D-glucose injection tool. So basically, we place it around the syringe, basically, and now suddenly have actually the ability to actually create a jet. Can actually see that? So basically, because I have this grip tool, I can actually go underneath the skin, and the jet goes to the nerve. So I don't have to go close to the nerve to actually treat the nerve with the glucose, which makes it very safe, especially in frozen shoulder, where you have a lot of important nerve structures that you don't want to touch with your needle, but you actually can still treat the nerve, surround the nerve with the dextrose solution without actually using your, threatening the nerve with your needle tip. Very important. Yeah.
That's right. I think, and after people see that, they'll feel a bit safer having it. I mean, mind you, when I first went to Dr. Praet, he goes, no, that's okay. You can look at it. And I didn't want to look at it because I was so worried about it.
Yeah.
And he goes, no, it's a very thin needle.
Yeah. I had several patients with needle phobia, and they were happy to trial it. And then afterwards, they said, "Oh, this is actually a much different, completely different experience." So it's really minimally invasive. Yeah. So and that's important. I mean, but to be honest, this is a refinement of the technique that I learned from Dr. Liftoft. He basically invented this. He's a doctor in New Zealand who travels around the world and training other doctors about this technique. Yeah.
Okay, so I just wanted to say thank you first to everyone that's been watching. We've had about 150 people watching our different platforms. So we are on YouTube and Facebook. We do have a few questions here, some clear and some not so clear. So yes, I've asked the others to just clarify the questions, but let me just go through them. Oh, just before we do that, I just want to say hello and thank you to Georgina, Kiru, Rinu, Sula, and I apologize to the others because I couldn't quite look at all the platforms at the same time. I'll be able to see more closely at the end of this event exactly who you are that have joined us. But Dr. Praet, we've been seen in Dubai, India, Philippines, Macau, Singapore, and Georgina, she's from, I forgot where you're from, Georgina, somewhere in the Mediterranean.
Okay.
Okay. So thank you for that. And I've got a question from Renu in India, and she said, chronic knee pain is what my mom suffers from. Could this be related to myofascial adhesion, and could it unlikely be arthritis? So I guess she's not quite sure what it could be. And she's saying she's having on and off pain, but very severe. So she wants to know if PIT would be an option for her mom.
Yeah. Well, there could be underlying issues with what we call osteoarthritis, which actually causes can cause capsular tightness of the knee joint, swelling and capsular tightness, and that actually the joint capsule of the knee is highly innervated, as you know, and that swelling or tightness that you can develop can actually also limit the blood flow to those tiny nerves that innervate the joint capsule. If that's the case, then she would be a good candidate to trial PIT or neural prolotherapy. Interesting, there have been studies done on hypertonic glucose injection with people with osteoarthritis of the knee, and I use that also sometimes. And they're using a hypertonic solution, 15% dextrose, in combination with lignocaine, with randomized controlled studies where they combine it with exercise. And actually, they show that if you do placebo injections versus dextrose injections with hypertonic glucose around all these painful points around the knee joint capsule, actually, in combination with exercise, you get a better result than just placebo injections, and better than just exercise only. And that was a study been published by David Rabago's group with a 1-year follow-up. So that was a pretty interesting study. Now, what I've learned I started doing hypertonic glucose initially for treating an EOA, but I've discovered that some subgroup of patients basically have maybe some osteoarthritic problem, but actually the main issue is that because they've had some pain, their muscles become so weak that they're actually overstretching their fascia and joint capsule constantly. And so because when you're using 5% dextrose, you don't have to use an anesthetic, and that actually gets very similar outcome and creates a window of opportunity to do the exercise. But again, just doing injection without the exercise program is not going to give you long-term benefits. So I would highly recommend that. I think there are doctors in India who have been trained by Dr. Liftoft who actually offer this treatment. So probably start with the PIT. If that doesn't last, then probably go to the hypertonic dextrose, where you have to use an anesthetic, trying to create a new healing response.
Thank you, doctor. Okay, we've got another question here, and this is from Indonesia. If I can put it, here we go. So Connie's saying, this injection, approximately how long for a treatment? It is not a lifetime, is it? I have heard treatments with injections before, but they last for a lifetime. So How would you answer that, doctor?
Well, I think generally, I think if you want to break that pain cycle and create a window of opportunity to do the exercise and strengthen the muscles, I normally do like 2 injection sessions about 7 to 10 days apart. That settles the pain. That gets people going with the exercise program, and subsequently, I see them after about 4 to 6 weeks again to top it up. And actually allow them to actually continue with the exercise program. So once they have regained that muscle activation around the joint, then it actually you don't have to keep on repeating it. It depends how flared up the nerves are. Yes, it's not a lifetime treatment, because if you settle the nerve pain, but you're gonna basically suddenly increase your walking distance from like 1 kilometer to 10 kilometers, I can guarantee you after those 10 kilometers, it's gonna come back the next day. Because you haven't really, but you've been overstretching the tissue too much. But so any healthy athlete, any healthy person can get pain in the fascia and overstretching the nerve if you overload the tissue. If you do this with your wrist all the time, anyone's gonna, after 10 minutes, we all start developing pain here. Even the healthiest athlete. But if you do this and your muscles are active, you won't develop pain in that same spot. And that's a general principle that applies to any joint. That applies to the jaw, the shoulder, the wrist, the elbow, the knee, the hip, the ankle, basically. So the injections create a window of opportunity that you settle the pain, and that allows you to start recruiting the muscles, strengthen the muscles, and that's going to give you the long-term benefit.
That's right. So it's like what we're doing right now with my treatment doctor, isn't it? So we're getting rid of the pain so that my physio can actually help me with working that muscle, strengthening that muscle, so that the pain eventually goes away, because the muscle can do the functions that it was meant to do, or that it's able to do.
The muscles are connected to the fascia, and by pre-tensioning the fascia, you basically protect the nerve from being overstretched. Right? Any nerve that you overstretch will become painful. But if your muscles are strong enough, you actually prevent that from happening, repetitive overstretching and putting pressure on the nerve when you're active, basically.
Awesome. Thank you. We have another question here, and I'm going to try and read it. Okay, so glucose and nerves. What is the relationship with the two? Why is glucose able to actually allow the nerves to relax?
Yeah, it's a good one. Basically, that goes back to the study from Brian McIver, where they look at this in a very specific area of the rat's eye, basically the cornea, where they have solely C fibers that innervate that tissue. So the nerves, a bit like our brain, we can travel to 6,000 meters and go and get exposed to hypoxia and still survive. Our brain will survive at 6,000 meters for most of the time, most of the people, although some people get altitude sickness. But if you got deprived from glucose for 2 minutes, basically you faint, and after 5 minutes your brain dies, basically. So some of our neural tissues are highly dependent on supply of glucose to generate ATP and basically maintain your neural tissue in a healthy way, because neural tissue is highly metabolically active. So it uses a lot of glucose. It cannot use any other substrate, as far as we know. You cannot use fat. You can't burn fat and then actually supply your nerves with a source of energy. So our nerve tissue, and especially the C fibers, are highly depending on sufficient supply of glucose. You think that answers the question?
Yep. There is a follow-up to that one, and it says, amazing, I didn't realize hypoglycemia affected tissues as well. Is that different from hypoglycemia in diabetics? Does it only affect diabetics, or do everyone suffer from hypoglycemia in their tissues?
Well, people with type 1 diabetes, or people who are using insulin therapy, they actually are at risk of developing hypoglycemia, and that also we think that actually people with type 1 diabetes is a cause of nerve pain later on in life. So when they get this repetitive exposure to low glucose levels, then nerves actually respond to that, and they develop diabetic neuropathy. That's one part of the story. Also, diabetes patients also have a poor blood supply to the nerves, and that actually can also drive neuropathy and pain. So these people often complain initially from that they develop in their hands and in their feet pain sensation, basically, and subsequently becomes numb because the nerves become chronically damaged. I don't think that healthy people normally develop hypoglycemia because we've got all sorts of escape mechanisms that actually prevent that from happening, that your glucose level drop below a certain level unless you would inject yourself with insulin. But the only thing that's going to happen locally is that if you put a lot of pressure on tissue and you reduce the supply of blood, oxygen, and glucose to the nerves, you're definitely going to develop a local glycopenia in that area, and that can actually drive nerve pain.
Awesome. Thank you, doctor. Yeah. Okay. Just going through the questions here. Okay. Can neural prolotherapy be used for varicose veins?
No. Prolotherapy, yeah, the hypertonic glucose. I wouldn't. I think there are other substances that would be more appropriate for that. You want to induce a sclerotic response. I think that's what it's about. In theory, you could, but I don't think that glucose is the hypertonic glucose is the best way to do that. Even with sclerotherapy, I mean, I'm not a dermatologist, but what I know is that sclerotherapy doesn't have a 100% success rate in varicose veins. So, injecting hypertonic glucose in blood vessels can be tricky because it can actually cause blood clots as well. So I wouldn't recommend prolotherapy as a treatment for varicose veins, to be honest. Yeah.
Okay, and another question. Actually, before I read this next question, we were chatting about lymphedema previously when we were talking in your clinic. And could you just explain to us, with people who are having issues with that, I think you've mentioned that you've done or you've helped a client to help them with their lymphedema. Was it like a good accident that happened, or?
No. This is a patient who had been chronic idiopathic lymphedema, so it's a really swollen legs. What happens with lymphedema is you get also this increased pressure in the interstitial space, so there's going to be increased pressure on the nerves and reduce blood flow to those tiny little nerves, which can cause pain. And what we did in this patient was actually first, and this patient couldn't sit down with her legs for more than 2 minutes. That's how painful it became. So we treated those nerves, so supplied the nerves basically around the legs with this glucose. And she already had surgery, etc. So trying to cause fasciotomy to take the pressure off, but it didn't work. So we used the glucose injection to settle the nerve pain, and then actually send her to a lymphedema therapist to actually improve the gliding of the fascia. And that actually, and by getting her more active, she actually her muscle pumps started working better. So she can sit down with her legs for up to I think almost an hour. She's been walking now much more frequently. So we broke that cycle basically of increasing lymphedema causing nerve pain, and actually reverse that. So now she's more active. She can actually manage her lymphedema much better together with a lymphedema therapist.
Awesome. All right. Can sciatica benefit from perineural injection treatments?
Depends where the sciatica is coming from, because sciatica is a very general term. If it's caused by a nerve root entrapment from a disc that's basically collapsed and that presses on the nerve root, I'm not gonna do a lot, I'm afraid. But actually, there's a lot of people who have so-called sciatica. They have the symptoms that mimic sciatica, which are caused by myofascial tightness in the gluteal area, in the area of the glute muscles. And those respond extremely well. So sometimes when I'm not sure, I actually use the perineural injection therapy to see whether their sciatic symptoms are coming from the more peripheral nerve entrapment rather than the nerve root entrapment. And I recently had a similar case with someone who actually had a disc protrusion at the cervical spine, or at C7 level, had a cortisone injection, didn't do anything basically. And the MRI was looked very clear. There was actually nerve root compression, and it seemed like it mimicked symptoms. But the cortisone injection didn't do anything. So what I had overlooked is actually he has a thoracic outlet problem. So basically he had pressure in this area, basically pressing onto the bundle of nerves that just outside of that spinal canal, and purely because of poor posture and muscle tension. So we did an injection in the thoracic outlet, and immediately his symptoms actually improved, which actually showed that his pain problem was not coming from actually the nerve root compression, although it was there, and you could see it on the MRI, but it didn't explain, it was not compressing and causing the pain. So, and the same can happen in sciatica in the lower back, basically. So sometimes you have a combined problem, and sometimes I use these injections to actually differentiate between, is it a nerve root problem or is it actually a more distal problem from the fascia?
Awesome. Thank you, doctor. I've got another one here. Before I read this one, I just wanted to let everyone else that's watching know, can we please refrain from putting your doctor's names on the chat? I really don't want to, you know, it's almost like calling out your doctor for something that you think is wrong. I really don't condone that here. If we can just remove that, we've had some removed. But this question, Dr. Praet, is about someone that's had surgery of the knee, but after surgery, the pain still kept coming. So she's asking if she could actually benefit from PIT, or if it's something that she cannot opt for anymore because she's already had surgery.
It depends where the pain is coming from. Again, I mean, I've had patients who had who've been operated for, say, a meniscus problem that you could see on the MRI, and they had the surgery, and the pain was still there, and because they had overlooked that some of the branches that innervate the area of the joint just outside of the meniscus was actually the cause of the problem. So once we treated that, actually the pain was gone. So I had patients who actually, so we reverted to say, well, there's a meniscal problem on the MRI, but it could also come from the capsular tightness that you developed. So let's target that first and see whether your pain is still there or not. So again, you use it sometimes as a safe way to differentiate between where the pain is coming from. So yeah, having had surgery doesn't mean that I'm not sure what sort of surgery they've done, but that you can't have any pain, because the surgery might not actually have addressed the source of the pain. And remember, our cartilage in our knees and our meniscus don't have the cartilage of our knee doesn't have pain receptors. Only the subchondral bone has pain receptors. So most of the knee pain is actually not coming from the cartilage problem. It's actually coming from the inflammation of the knee joint and the inflammation of the nerves that innervate that joint capsule of the knee, for instance, as an example.
I love how you said that, because the next question is related to that. So let me just try and rephrase this a little bit. It's a little bit long. So, okay. Anyway, so I've had difficulties with inflammations of my knees and a lot of knee pain, but it's because of no more cartilage in my knees. So doctors have said I've got no more cartilage in my knees. Can PIT help with this one?
Maybe temporarily, but if there's no cartilage left, it can be really. I don't think it's going to last very long, to be honest. It's worth. It depends on how much cartilage loss there is, but we have different stages of osteoarthritis, and my experience that and also based on the research that Calvin and Lawrence stage 3 and 1, 2, and 3, that's basically they still respond to prolotherapy or neural prolotherapy. Stage 4, the end stage, I don't think there's any study that shows a long-term effect of that. So not something I would typically recommend if there is absolutely no cartilage left, basically, and then often we have to refer to joint replacement surgery for that sort of things. Yeah.
Okay, awesome. Thank you, doctor. All right, just trying to see if there's any more that we've missed here. I think we're good. If you've got any more questions, just type away. Again, if I don't see them, sometimes they don't come up straight away because on our live feed, there's actually a bit of a delay. But if we see them, we'll respond to those questions straight away. If not, then we'll see if we can forward the questions later on to Dr. Praet. Dr. Praet, we were talking about how there are different doctors that do this type of procedure that's or done the training with Dr. Liftoff. You've given me the site last time. Could you just give that to me again so we can type it up and give it to our audience?
Okay, let me just double check this because it's
So I have seen this site.
Google Liftoff perineal injection therapy. So www.lyftogtmeg.com. That basically, I can actually type that here in my.
Oh, that would be great.
Yeah,
yes.
yeah.
And then we can share that screen.
Mm-hmm.
So what we're looking for right now is this list of doctors that you could check out if you're outside Australia, if you're outside Canberra even, and you wanted to do this procedure or ask about this procedure to find out if it'll work for what you're suffering from. It'll be good to just check out this website. Yeah. Dr. Stephan, do you want to share that screen?
Oh yeah, sorry. I'm just sending the link.
Okay, sorry, in the chat.
Yeah, but I'll do that just straight away here. Yeah, so I'll let's see here.
Okay, so this is the site that you can check out. That Dr. Praet shared with us.
Share screen. So yeah, so this is Dr. Liftoff's web. Actually, he's Dutch, but moved in '73 to New Zealand, and he used to be a very fanatic runner. Developed pain around the Achilles tendon and discovered that you can use 5% dextrose to use Achilles tendon pain to treat the Achilles tendon pain. So where to get Liftoff PIT? That's the only list of doctors who have had the advanced training course, but you probably can also send their. You can look at a different country. Can you see this here?
Yes.
Yeah. So yeah, like the Philippines, I think there are a couple of doctors who have been trained doing the advanced training. So there are definitely doctors who offer that sort of thing. But you can actually look per country who has done the masterclass training by Dr. Liftoff. Yeah.
Awesome. Thank you, Doctor.
It's a very very educational website that gives you some more background information. Some of the slides I was showing are actually have to credit Dr. Liftoff for that. But he's been doing this for 20 years, I think. So yeah, and now training other doctors in the world about this. Yeah.
That's right. So thank you so much for sharing that with us. It's a really amazing information, and I think really crucial information for people to be aware of. Again, unless you understand everything about a procedure, you'll never know if it's for you or if it isn't for you. Yeah. And like I always say, once you've been told that you need a certain procedure, just always see what else is out there, because there's no one size fits all. There's no one pill for everyone or not one procedure for everyone else. Dr. Praet, thank you so much for your time. And thank you for clarifying to everyone, what their options are. My procedure we've been doing PIT on me for I think about 4 weeks, almost 5, or almost 5 weeks. We'll be doing the next treatment tomorrow, actually. Tomorrow, and I'll keep you updated as well with that. And I think, Dr. Praet and I talk about how the progress is going, and I was telling Dr. Praet, although you're not, like, I don't feel 100% pain-free, I still have pains. I don't have the same pains at the end of every treatment. So actually, doctor, if you could just explain that a little bit. So when we first did the treatment, there was a movement that I could do better than how it was before. I remember, if you've had a frozen shoulder, one of the things that you can't do is if you get excited or you jolt, all of a sudden that's extreme pain. In fact, me just doing that, there was a bit of a pain, but it's nothing compared to what it was when I first had it or before any of our shots. I remember I'd have excruciating pain. I'd be crying because of the pain. After every treatment, the pains would be different, especially depending on what we've targeted. And in my last physio appointment, we were doing some stretching exercises, and even my physio said, my range has gotten better, and the pains are now in affecting different types of movements that we're trying to do, because we're trying to be a bit more, how to say it, not aggressive, or maybe aggressive with what we're trying to do, so that the movements would be better.
Yeah.
Right.
But the general misconception about, that's my experience with frozen shoulder, is that it's a pure. The general idea is that it's adhesive capsulitis, which limits your movement, and everyone overlooks that actually the fascia also plays a role. So the fascia that overlies your shoulder muscle basically and goes to your chest and to the back of your shoulder blade, etc., your arm, that's like a sleeve, three-dimensional web, that also gets very tight. And actually, when that gets tight, the nerves that penetrate the fascia and go back to the innervated joint capsule also becomes tight. So basically, you end up with a very tight shoulder joint. Not just because there's an adhesive capsulitis, but also because the fascia and the nerves are actually involved. And the idea of the neural prolotherapy, or PIT, is that you actually target those nerves that are involved, and that it causes immediately relaxation of the fascia, and that actually immediately causes your improved range of motion, which gives that window opportunity for the physio to actually start regaining your mobility, sliding of the fascia, and start training the muscles because it's not painful. And that's something completely different from a traditional corticosteroid injection, where try to, maybe it works a little bit, but not as effective in my experience as what you can achieve with if you target all the different nerves. But remember, there are 5 different nerves innervating the shoulder joint. They have to treat all 5 of them properly in order to get a good result. If you and that's often based on experience that the doctor has with this treatment. You're not just blind. You have to really know where you're injecting and which nerve you target, and know your anatomy very well in order to get a good outcome of this. So that's.
Right.
So I think you mentioned frozen shoulder is probably not the right name for actually the problem.
Adhesive capsulitis, yes. Or the other, I think the other name that people have put is rotator cuff injury.
Yeah, well,
that's another one that I've heard people call it.
But which can flare up your joint capsule and the fascia as well. Obviously, it's like you get swelling of the tendons when you have a rotator cuff tendinopathy, and that actually limits. That cause swelling of the joint capsule, which can drive that nerve pain as well. So it's it's not there's not a single answer to every problem, and you have to understand the biomechanics, you have to understand tissue healing, you have to understand the nerves. I guess that's why we have to spend so much time in med school, right? So
that's right, and I think for everyone else that's watching here, it's again going back to what is it that you're wanting to do, what is it that you're willing to experience in terms of pain. I've done cortisone injections when I had frozen shoulder on this shoulder about 5 years ago, and didn't want to do the same thing here because I was in pain during my whole physio treatment despite the cortisone shots. So thank you so much, doctor, again for your time. Thank you for agreeing to go a bit over time. And for those of you that have more questions for Dr. Praet, please just put it on our chat, and then I will try and forward them. Dr. Praet's a very, very busy doctor, so truly appreciate your time, doctor.
I can't promise I can answer all of them, but yeah, we'll see how we go.
That's right. We will try. Thank you so much, Doctor.
Okay, bye-bye.
Again, guys, thanks for watching. Thanks for joining me today. And if you've got any questions, or if you want to share your experience with your frozen shoulder, the experience with the treatments that you've undergone, do share it here. As I've shared, I've done acupuncture for my frozen shoulders. I did chiropractic, did physiotherapy. I do use a lot of herbs for anti-inflammatory, for rebuilding of my muscles, rebuilding of my ligaments. I use supplements as well that will help rebuild my system. So it's a combination of different things. It's not just one thing. But what I found in terms of mobilizing it to be able to actually treat my frozen shoulder, I have to say the combination of the PIT with my physio is what's helping the most. I do like having my chiropractic adjustments as well. But during this period, because we're fast tracking my recovery by having my my treatments close together, I haven't done just that. My physio's done really well with adjusting my neck and my stiffness that I get, after a while because of the limitations of my shoulder. But I have to say, it's been amazing. I went from not being able to sleep any other way except this way and being in excruciating pain, even if I sleep straight, to being able to sleep on my sides now and being able to sleep through the night. I do still wake up with pain, but not anywhere close to what it was previously. I can do more things. And I think at the end of the day, that's what it is. It's about what best works for you to allow you to do what it is that you're wanting to do. And with me, I don't like I don't like stopping my activities. I don't like not being able to do the things that I need to do and want to do. One of the things that was quite difficult was bushwalking, because if it got slippery and I slid and I jolted, then it actually hurt my shoulders and would just ruin our walk. We're being able to do more of that now and just reaping the benefits. So again, thank you for everyone that's watched. Let me just again check comments online. Okay. I will be thanking everyone that's joined. Again, I can't figure out how to look at it while the live is going on. So apologies for that. But truly appreciate everyone here that's been following my Cuppas, my live FBs, and my programs. If you've got any questions, send it on the chat. If you don't want it to come out of the chat, send it to info@michelletjones.com. Thank you again for watching, everyone, and have a great day. I hope that has enlightened you and given you more options for pain relief, for your injury management, no matter where you are in this world. So again, if you look at that website, which I will share one more time here. Where did I put that? Just give me a sec. Here we go. If you check this website, you'll be able to find the different doctors from the different countries that have done this training and might be able to help you. But just remember, Dr. Praet shared the type of needle he uses. And again, I really think that's a big game changer, because when you do perineural injections, we're not talking about just one shot. We're talking about multiple shots following the nerves so that the pain disappears, so the inflammation on the nerves disappear. So we're talking about 20, 30, even 40 shots, depending on how big the injury is, how bad the inflammation is, and how bad the pain is. And if you're doing multiple shots like that, having the thinnest needle used on you is really, really crucial. All right, guys. Thank you for watching and have a great day. Bye-bye.